Hi, my name's Matt Yurgelun. I'm the director of the Lynch Syndrome Center at the Dana-Farber Cancer Institute in Boston, and I want to thank the organizers of the FORCE conference here for asking me to talk today. My talk is going to be on what's new in hereditary cancer, focused specifically on Lynch syndrome. So my disclosures are as follows. So brief outline for the talk. I'm going to start off with a couple of example cases, which hopefully will set up the stage for the rest of the talk. I want to talk about some new advances on how we're really moving away from what I would call a one-size-fits-all management to individuals with Lynch syndrome. Talk about some exciting data looking at chemo prevention in Lynch syndrome, specifically with aspirin, and then a lot of really exciting new biology and upcoming clinical trials focused on immune-based treatments and also immune-based strategies for prevention, vaccines in individuals with Lynch syndrome. So a couple of quick cases. I'm going to start with a 27-year-old female who has never had cancer, who has a pathogenic germline MSH2 variant, a so-called mutation. Her family tree is as follows. Her father had ureter cancer at 44 and colon cancer at 47, later dying at 48. Her paternal aunt had colon cancer at age 42 and is still alive at age 58. And her paternal grandmother had numerous Lynch syndrome-associated cancers, ultimately dying at age 75 of advanced pancreatic cancer. So what are the future risks of cancer for this specific individual? And what patient-specific factors, what aspects of her own clinical history might be used to influence our own risk assessment of her cancer risk for somebody like her with Lynch syndrome? And then to contrast it, what if we switch this and instead of MSH2, we're looking at PMS2, and we're looking at a bit of a milder family history, still a father with colon cancer, a paternal aunt with breast cancer this time, and a paternal grandmother who still died of pancreatic cancer, but maybe didn't have as striking of a history before that. How much does the specific gene in the case of Lynch syndrome influence both the magnitude of cancer risk and also the spectrum of cancer risk? And then does the individual's family history in and of itself actually play a role in how we assess their risk? So some basics about Lynch syndrome that I think have already been covered over the course of the conference here. Lynch syndrome is common. We think it accounts for about 3% of all colorectal cancers and about 2% of all endometrial cancers, also known as uterine cancers. And we think about one individual out of every 279 in the general population has some form of Lynch syndrome. Lynch syndrome is defined by the presence of what we would call a pathogenic germline variant, also known as a mutation, in one of the DNA mismatch repair genes, MLH1, MSH2, MSH6, PMS2, or Epcam. And now that we've understood really the nuances of these 5 different genes, it really can be thought of as 5 different syndromes, all of which fall under the umbrella of Lynch syndrome, as I'll get into. It used to be in the olden days, like 7-8 years ago, we were taking a one-size-fits-all approach to how we managed individuals with Lynch syndrome, really regardless of patient-specific factors like age, sex, the gene, the family history, with a long list of cancer surveillance approaches like what's listed here: frequent colonoscopies, frequent upper endoscopies, also known as EGDs, annual transvaginal ultrasounds, TVUS, and endometrial biopsies for young women, risk-reducing surgery, removal of the uterus and the ovaries for women by age 40, and so on and so forth down this long list. As we're understanding more about patient-specific factors that really influence organ-specific risk, we're learning that this approach, what I would refer to as a throw the kitchen sink at it type of approach, where everybody gets screened for everything, might be overkill for the majority of individuals with Lynch syndrome. Add to that the fact that a lot of this organ-specific screening is actually of pretty questionable benefit. When you really get right down to it, of the interventions listed here, the ones that really have a proven track record of either reducing cancer incidence or even reducing the likelihood of dying from cancer, it's a relatively small list here of this long list that's typically part of the Lynch syndrome treatment plan. I'll come back to the aspirin piece a little bit later, but I think this is where you can see that there's some higher yield pieces to the screening and prevention than others. And we really want to make sure that our risk reduction plans for individuals with Lynch syndrome are tailored to their specific risks. So what influences an individual's risk of specific Lynch syndrome cancers? how do we use that to individualize our risk assessment for a specific person with Lynch syndrome? I would break it down into there being non-modifiable factors. These are factors you can't really change about yourself: your sex, your age, the gene in question when we're talking about Lynch syndrome, and then your family history of cancers. And then there are also modifiable risk factors. What sorts of screening and/or surgery have you had or are you planning to have? What medications are you taking? Again, aspirin. Lifestyle factors such as diet, exercise, environmental factors, those sorts of things that are actually kind of hard to measure. A lot of what we're going to focus on in this next segment of the talk are the non-modifiable factors, which are relatively easy to assess. And so breaking it down, as I mentioned, I would think of Lynch syndrome nowadays as almost being 5 specific syndromes all wrapped into one, where looking at the gene in question is particularly important. So if you look at data from the Prospective Lynch Syndrome Database, the PLSD, they've really shed a ton of important light on how these gene-specific differences should be thought of. MLH1-associated Lynch syndrome, I would classify as a high-risk form of Lynch syndrome. Based on their data would say that for an individual with MLH1-associated Lynch syndrome, the lifetime risk of any Lynch syndrome cancer is 71 to 81%, depending on if you're male or if you're female. In particular, the risk of GI cancers is notably high, with a lifetime risk of colorectal cancer of 57% for males and 48% for females, but still also a significant lifetime risk for upper GI cancers, more so than what you see in other forms of Lynch syndrome. Contrast that with MSH2-associated Lynch syndrome, still a high-risk form of Lynch syndrome with lifetime cancer risks well over 75% for both males and females. One unique aspect of MSH2, however, is that there's a particular risk of urinary tract cancers with MSH2, particularly for males, much more so than you see in other forms of Lynch syndrome. I would also say that MSH2-associated Lynch syndrome has far and away the widest spectrum of increased risk across really the different organ systems that we think about. The upper GI tract, the GYN tract, as I mentioned, the urinary tract, the skin. We're learning now even sarcomas as a rare manifestation of MSH2-related Lynch syndrome. MSH2 seems to be able to hit more organ systems than other forms of Lynch syndrome, statistically speaking. Contrast that with MSH6-associated Lynch syndrome, where there's still a high risk for GYN cancers, high lifetime risks for uterine cancer and ovarian cancer, really on par to MLH1 and MSH2-associated Lynch syndrome. However, if you look at the GI tract, for whatever reason, MSH6-associated Lynch syndrome does not affect the GI tract nearly as frequently, where the lifetime risk for colorectal cancer is still elevated, but not nearly to the extent that it is with MLH1 and MSH2, 18% for males, 20% for females. And then I think the biggest outlier is PMS2-associated Lynch syndrome, where across the board, the risks actually seem to be more modest. They're still significantly elevated. It's still a real syndrome, but it's not quite the same as some of the other genes that I mentioned. The lifetime risk of any Lynch syndrome cancer with PMS2 is a good deal more attenuated, 34%. Contrast that to the 70+% we were seeing before. And some recent data from the PLSD suggest that there may only be increased risks for colorectal cancer and uterine cancer with PMS2, but maybe not for these other cancers that we classically think of as being Lynch associated: ovarian cancer, upper GI tract cancers, urinary tract cancers. There's still a lot of work to be done in this space, but the more we see of PMS2, the more we're seeing that the risks may be primarily limited to the colon and to the uterus compared to the other forms of Lynch syndrome. And then lastly, Epcam-associated Lynch syndrome is the one that probably remains the biggest mystery still, mostly because it's far and away the rarest form of Lynch syndrome. We really don't have good quality data. We certainly have seen that there are high lifetime risks for colorectal cancer. And because of the biology of Epcam, we think it actually has quite a significant overlap with what we see with MSH2-associated Lynch syndrome, but that really is more of a theory than it is something where we've got clear-cut data. One or two websites I would encourage you to check out. There's the risk calculator from the PLSD. It's www.plsd.eu, where you put in your sex, your gene, and your age, and this will spit out organ site by organ site an estimate for that individual person's future risk of cancer. Similarly, my colleagues at the Harvard School of Public Health have put together this risk calculator called Ask2Me at www.ask2me.org. Similar sort of thing. You put in the gene in question, your age, your sex, and it will spit out risk estimates for that person's future risk of cancer. Ask2Me also has non-Lynch syndrome forms of cancer risk estimation. I would caution you that all these are statistics and not necessarily meant to be gospel here, but really these can be helpful guides at really kind of understanding, which aspects of cancer prevention are the highest yield for an individual person. So what about family history? These types of calculators are great for looking at age and gene and sex and those factors, but how does family history play in? A lot of clinical practice guidelines that are out there recommend that we clinicians use somebody's family history to guide screening for some of these less common Lynch syndrome cancers. For example, that we screen people for urinary tract cancer if they've got a family history, but really only if they've got a family history. Certainly, we see that there are some families that have clustering of certain cancers, but is that just purely driven by the fact that there are gene-specific aspects to this, or is the family history important in and of itself? So these are data that our group recently published earlier this year, trying to answer this question. And a few things kind of boiled to the top here. Just to walk you through what we're looking at, any number that is north of 1 here indicates the degree of increased risk. So for example, we saw that in our data set here of over 3,800 people with Lynch syndrome, males were about 4.8 times more likely to have colorectal cancer than females if you controlled statistically for other factors. Similarly, looking at other cancers, we saw urinary tract cancer, small bowel cancer, sebaceous neoplasms, which is a type of skin tumor, gastric cancer. Those were all seen more commonly in males, fitting with what we see from data from the PLSD and elsewhere. Similarly, MLH1, we again saw a significant link to GI cancer risk. Contrast that with MSH2, where again, you saw this broader spectrum of risk, particularly focused on the urinary tract, but really looking across different organ systems. But one thing we had here that was, I think, a bit novel was looking at the notion of family history. So per affected relative, we saw that these cancers actually, there was a significantly increased risk of the individual themselves having cancer. So for example, for small bowel cancer, for every relative this person has with small bowel cancer, they themselves are at 3 times higher likelihood for having small bowel cancer themselves. And that's particularly important when you're looking at rare cancers, but where there's been a clustering in families. And this seems to be an effect that's independent of the gene that's being looked at here. So I'm going to switch gears now, talk a little bit about chemo prevention and some of the exciting data that have come out looking at aspirin to reduce cancer rates in Lynch syndrome. So there have been large volumes of data over the years, really mostly from the cardiovascular literature, where aspirin is frequently used to reduce rates of strokes and heart attacks. The one finding that has really kind of bubbled to the top time after time is that individuals taking aspirin seem to have lower rates of colorectal cancer. It's been a consistent finding. Now, if you look at it in people who have average risks of colorectal cancer, you essentially see a pretty small but consistent preventative benefit. That's led to the question, though, really, what if you look at people who have higher risks of colorectal cancer, specifically people with Lynch syndrome? Is there a larger preventative benefit if the baseline risk is that much higher? And so that's really the key question that was the foundation for this seminal study called the Cap2 study, which was looking at aspirin in Lynch syndrome. So the Cap2 study is one that has been going on for a couple of decades at this point. Originally looked at 861 individuals with Lynch syndrome. I'll point out that they only looked at MLH1, MSH2, and MSH6 related Lynch syndrome, in part because we used to have a hard time finding PMS2 related Lynch syndrome. These were individuals who were recruited to the study from 43 different countries, so very much an international study. People who enrolled in this study were randomized to take daily aspirin, a pretty high dose, 600 milligrams per day, versus a placebo. The study participants themselves did not know what they were taking. Their doctors didn't take it. It was a true double-blinded, randomized clinical trial, as the title there infers. And the punchline from the latest update of the Cap2 study, just published a little bit more than a year ago, was that for the individuals in the study with Lynch syndrome who took aspirin for a minimum of 2 years, they had more than 40% fewer colon cancers, colorectal cancers, than those taking placebo. And that's what's illustrated in these various graphs to the right here. Each one looked at a slightly different statistical measure. But if you look at the blue lines, that is the rate of colorectal cancer in individuals taking the placebo. And the red line is the rate of colorectal cancer in individuals taking aspirin. And the follow-up here, this is starting at enrollment here. This is starting after people had taken 2 years of the drug. And this is going out all the way to 20 years of follow-up. This was a long-term prevention study. One interesting aspect of this is that there was really no significant difference if you look across these various graphs in the first several years, really the first 5 years or so. There's really no statistically different rate in colorectal cancer between those taking aspirin and those taking the placebo. It's a delayed benefit. That kind of makes sense. You would assume that any sort of prevention study looking at preventing cancer, that cancer probably does take several years really to develop. So starting an intervention now might not prevent a cancer 6 months or a year from now, but it's going to have a very powerful protective effect as the years go by. And then one important aspect to this is what we called a legacy effect of the aspirin. In other words, in this study, people took aspirin for a finite period of time, a little bit more than 2 years, and then they came off of the study. But in spite of that, you saw that really there was this continued preventative benefit going out as far as 20 years here. So taking a finite amount of aspirin really did have a lasting preventative benefit. Now, they didn't know and weren't able to catalog whether or not people went to take aspirin once they stopped the study. So it may be that the people in this study, that some of this legacy effect was kind of colored by ongoing aspirin use. It's a little bit hard to say, but point being, it's not like the people who were taking placebo eventually caught up after the fact. This is a pretty powerful and sustained degree of prevention. Importantly, they did not see significant differences in the rates of other Lynch syndrome cancers. It's not clear if this was just because there was no impact or because there were rare enough events that it's hard to see statistically. They did see lower rates of uterine cancer in those taking aspirin, but it wasn't a difference that was considered statistically significant. So it's not clear if that was actually a meaningful effect. There is a follow-up study right now going on called the Cap2 Study, another international effort led by many of the same investigators, which is looking at different doses of aspirin to try to see if lower doses of aspirin can confer the same protective benefit. This completed accrual in 2019, and they're following these individuals for a minimum of 5 years, and therefore results aren't expected until at least 2024. So stay tuned, but those are results that are not necessarily coming out tomorrow. I will point out some potential downsides to taking aspirin in Lynch syndrome, the delayed benefit being one, questions about uncertainties with the dosing of aspirin, and I think concerns about the fact that high doses of aspirin, including the 600 milligrams a day studied in the Cap2 study, for some individuals really can provide unacceptably high risks for complications such as bleeding, bruising, GI upset, or even ulceration in the GI tract. I'll tell you my approach to using aspirin in Lynch syndrome is really to use a risk stratified type of approach, where I look at that person's specific risk of colorectal cancer going forward, really going back to some of the points from the earlier part of the talk, looking at that person's age, their sex, and the gene, and to an extent the family history as well, to try to understand who is at the highest future risk for colorectal cancer. And in general, young individuals who presumably have 50, 60, sometimes 70 years of life in front of them are going to have the highest future risk because they just have more years at risk. Young individuals, particularly those with MLH1 or MSH2 associated Lynch syndrome and who have a fully intact large intestine, are going to have the highest future risks. And so that's where I consider the highest dosing, at least for a 2-year period, going off of what was used in Cap2. For the majority of individuals with Lynch syndrome, I would say a medium aspirin dose is probably pretty reasonable, somewhere between 162 milligrams, which is 2 baby aspirin, to 325 milligrams, which is 1 adult strength aspirin. But I'll consider even lower doses, just an 81 milligram per day dose, or even no aspirin whatsoever, for those who have rather low future risks of colorectal cancer, particularly older individuals with PMS2 associated Lynch syndrome. By older, I mean maybe getting into the late 60s, 70s or higher, where there may not be, decades and decades of life in front of these people, as well as people who have just minimal remaining large bowel. If there's very little large bowel left because of prior surgery, there may be very little protective effect here. And then certainly I would recommend against aspirin use for anybody who's at significant risk for complications. Again, people who are older, especially if they are using blood thinners at the same time, if they have a history of GI ulcers or bleeding or an allergy, if they have uncontrolled high blood pressure. And I would point out too that it's important to avoid aspirin during the early trimesters of pregnancy unless otherwise advised by somebody's doctor. And so lastly, I'm going to get into some discussion about exciting work in the immune space, both for treatment and prevention of Lynch syndrome-related cancers. As many people are probably aware, in 2017, the FDA granted accelerated approval to pembrolizumab, which is referred to an immune checkpoint inhibitor, a form of immunotherapy, and later nivolumab for treating any cancer with a phenomenon called MSI high. The other name for that is MMR deficient biology within the cancer itself. And that's a phenomenon, this MSI high, that's really seen in virtually all Lynch syndrome related cancers. There's rare exceptions. This FDA approval, this accelerated approval, was specifically for metastatic cancers refractory to standard therapy. So, it was highlighting the fact that for people who really were out of options, these can be important treatments. But I'll point out some recent data that have continued to change the landscape. This is from a study called Keynote 177, where they actually looked at pembrolizumab, the same immune checkpoint inhibitor, in people with untreated, newly diagnosed metastatic MSI high colorectal cancer. They compared it to chemotherapy. The response rates were higher with pembrolizumab than with chemotherapy. Not a humongous difference, but certainly real and important. But I think the more important piece was that of those who responded, the responses were really, really good and really, really long. 83% of those who responded had at least 2 years of response with pembrolizumab, and many going 3 years and beyond with ongoing response. Contrast that to only 35% of people who responded to chemo were still responding at 2 years. And so this led to an additional FDA approval of pembrolizumab for untreated, newly diagnosed metastatic MSI high colorectal cancer. Again, that was only for advanced disease for people with metastatic disease. And so I'll point out this ongoing phase 3 clinical trial looking at people who have had a resected stage 3 colon cancer, which is MSI high, where they're looking at chemotherapy plus immunotherapy versus chemotherapy alone. Chemotherapy alone is considered the current standard treatment. This trial is ongoing, but I think we're hoping in the coming years to have hopefully exciting new insight on whether or not immune therapies would be helpful for people with earlier and earlier stage colorectal cancers. And then lastly, I want to spend a couple minutes talking about immune prevention in Lynch syndrome. And so again, microsatellite instability, this MSI or MSI high phenomenon I mentioned a couple slides ago. Essentially what it is it's an accumulation of specific types of mutations within a given cancer specimen. These mutations occur at specific hotspots, specific genetic locations called microsatellites. That's where the term comes from. But what's important is that these mutations lead to an accumulation of a very specific type of protein called frame shift proteins or frame shift peptides, which we'll just call FSPs here. These are only present in tissues that have MSI. They're not present in normal tissue. And these frame shift peptides, these FSPs, are recognized by the immune system. The immune system will recognize these proteins as foreign, and therefore it's a tool for the immune system to recognize the cancer as foreign. What's important here, and the important link, is that you can predict these FSPs in somebody who might be prone to an MSI cancer. These FSPs, because the mutations occur at specific genetic locations, you can predict what these FSPs are going to look like. And therefore, theoretically, you can start to predict what sorts of factors might the immune system be primed to go after if this person is prone to developing an MSI high cancer. And so a lot of the early work for laying the groundwork for vaccines and Lynch syndrome comes from some work done by colleagues at the University of Heidelberg in Germany. This is a study published originally in 2008, so reasonably old work, where all of these boxes are basically meant to represent a detected immune response to one of these FSPs. So here they looked at a slew of different immune responses across a bunch of different patients, individuals who had had a prior or an existing MSI high colorectal cancer. They saw a bunch of immune responses to these FSPs. That's what all the dark boxes are. Contrast that in with somebody who has just a standard run-of-the-mill colorectal cancer without MSI. We call that MSS. These people had essentially no immune responses to any of these same FSPs because their tumor doesn't have MSI. So that makes sense, that all fits. But where it gets really interesting is when you look at healthy individuals with Lynch syndrome, which we used to call HNPCC, you see a lot of the same predictable immune responses, but these people have never had cancer. So there's something that the body is seeing, that the immune system is seeing. It's being primed, it's being exposed to these FSPs, almost like there's some auto-vaccination happening behind the scenes, where the immune system is already a little bit primed to go after some of these FSPs. And similarly, in healthy individuals who had never had cancer and didn't have Lynch syndrome, you didn't really see these responses. So this really laid the groundwork for saying, if healthy Lynch syndrome patients have circulating immune cells targeted against microsatellite instability induced FSPs, even though they don't have cancer, the immune system is doing something. The immune system is responding to things, and it probably is knocking down potentially precancerous phenomena before they're ever found, this phenomenon we call immunosurveillance. So that's planted the seed in a lot of people's head. Can you use the immune system and leverage this biology to prevent cancers? Well, people are starting to ask this question in real life human beings now. This is a study recently published looking at individuals with a known prior cancer. So not necessarily a pure prevention setting. They took 22 individuals with a prior MSI high or MMR deficient colorectal cancer, most of whom had known Lynch syndrome. This was an early stage study. So all they were looking at was trying to get a sense, is this a safe intervention, and does it generate an immune response? And the answer seems to be yes, with a small number of people. Everybody who was vaccinated in this study demonstrated a significant immune response through a variety of different metrics. There were no serious complications from the vaccination. Some people did have significant injection site reactions, but those were considered to be more bothersome than truly dangerous. And then more recently, the same group, again led by colleagues at the University of Heidelberg, demonstrated in mice, at least, the potential for really bringing this into the prevention space. They looked at a variety of these FSPs that were present in mice that were genetically prone to developing MSI-high cancers. They developed a specific vaccine that was particular to these mouse FSPs, and they administered it. And ultimately, they saw that the mice that got the vaccine versus those that didn't had significantly improved survival, had significantly reduced cancer burdens. And interestingly, when they gave these mice naproxen, which is a over-the-counter anti-inflammatory drug similar to aspirin, they actually found that naproxen use enhanced the efficacy of the vaccine, raising a lot of really cool questions about ways in which aspirin might be working to prevent colorectal cancer in Lynch syndrome. It might be more than just simple biology within the colon. There may be an immune aspect to this as well. And so then this is, I think, the hot topic in the field right now. When are these trials going to come into humans on a larger scale from the standpoint of pure prevention? Well, coming soon, and this is an NIH funded effort. It's expected that a phase 1 trial will hopefully open within the next year. And again, a phase 1 trial, really, the goal is to assess the safety and what I would call the immunogenicity of the intervention. Are people getting through this without major complications? And are they generating a robust immune response the way that they're supposed to? So it's a phase 1 trial, early on in the process here. They're planning to enroll a few more than 40 individuals. This website here describes more about the effort, scheduled hopefully to open in 2022 at 4 different sites in the United States, including Puerto Rico. And my colleagues Eduardo Villar Sanchez at the MD Anderson Cancer Center and Stephen Lipkin at Weill Cornell in New York are the primary investigators on this effort. I suspect that there will probably be other similar vaccine efforts coming soon as well, because this is such a hot area right now. Everybody is really excited about trying to learn more about this biology and how we can prevent these cancers. So in summary, we really are learning more about gene, sex-specific cancer risk estimation in individuals with Lynch syndrome, and trying to figure out how we can use that to facilitate tailored approaches to cancer surveillance in Lynch syndrome. And I would point out that family history may be a particularly important component that modifies risk and helps us understand risk assessment. I would encourage you to check out these 2 websites if you're interested in playing around with looking at some of the risk estimates that might be present in your family. I would highlight that daily aspirin reduces rates of colorectal cancer in individuals with Lynch syndrome by more than 40%. And that factors out to 1 cancer is prevented for every 24 people with Lynch syndrome who take aspirin. That's a really powerful preventive effect for something as simple as aspirin. We're expanding the use of immunotherapy for advanced cancers in the setting of Lynch syndrome. And there's ongoing studies looking at this in early stage Lynch colorectal cancers. And then, as I just mentioned, a lot of really exciting biologic advances coming soon in the name of immuno-based prevention, such as vaccines. So stay tuned for more on that. I'll be happy to take questions at the session later. Thanks so much.